It is such a pleasure to be here with you all today. As Patrick was saying, I've been at OHSU for a decade now, and I really love the work that I do around facial reanimation. To be able to restore people's smiles and facial movement is truly a passion of mine. And I've had the privilege of learning from Patrick, even his more recent descriptions of multivectors. So I know your department and your group is very well versed in the surgeries for facial reanimation. So today I thought I would shift our talk a little bit and talk about electric stimulation for facial paralysis. This is a topic that is a little bit different and might seem like it's not related to your practice, but I'm going to tell you why it matters to you and try to get to answer clinical questions that I think you are getting in your practice. And this has been an academic passion of mine in an ongoing collaboration with our neurology and physical therapy departments here at OHSU. So the questions I'm going to help you answer with this talk are, is electric stimulation helpful or harmful for patients with Bell palsy? And can electric stimulation be used intraoperatively to enhance facial nerve recovery? And your department is already doing work on this area. You are already using electric stimulation, and I'll talk a little bit more about what you all are doing over there during the talk. So why am I talking about Bell palsy? Bell palsy is still the most common cause of facial paralysis. 1 in 60 people in their lifetime will get it, and we think that it'll resolve on its own. Mostly the PCPs, emergency doctors, and neurology are seeing them. And the reality is that it doesn't fully resolve for everybody, and up to a quarter of patients, I believe an even higher percentage, develop lifetime sequelae. So for every one patient that I see with flaccid paralysis that is seeking reanimation, I probably see 50 people with sequelae from Bell palsy. And we all know about the significant impact that having facial paralysis has on facial function. I'm showing you a picture here of a face where you can see the left side is paralyzed. She's not able to raise her brow. She's not able to fully close and protect her eye closure. Her lower eyelid is sagging. She probably has nasal obstruction. The cheek is pulling down. She has difficulty with speech and diet. And perhaps the most important impact is the psychosocial impact. In this photo, I'm asking her to smile. And you can see that when you look at this face, you don't really immediately think that she's happy or trying to smile and conveys joy. So this slide here is the largest study on the natural progression of Bell palsy. And you can see when the patients have incomplete paralysis, 94% of them will return to normal. In that really changes when somebody has complete paralysis. If they had complete paralysis for longer than 3 weeks, the chances of having long-term sequelae really increase. And it's from this study that we get this 23% of synkinesis, hemifacial spasms, and contractures. So what does that really mean? What does synkinesis really mean? And what happens when there's this involuntary contraction happening in the face? Well, I have an example here of a patient with synkinesis, and you can see that when I'm asking her to smile, her eye is unintentionally closing on her. Her cheek is excessively tight. She's not able to raise that corner of the mouth and display her teeth during that smile attempt. And she's getting straining in her chin, in her mentalis, and in her neck. And all of this makes it so that when she tries to smile, she also doesn't quite convey joy. And it's hard to figure out what's going on, where some people think that they're smirking, they're quite not able to communicate non-verbally, as if they've never had this happen. So what can we do for Bell palsy? This is the New England Journal of Medicine from 2007 that proved that steroids were helpful in Bell palsy to speed the recovery and to improve the final stage of recovery. But the caveat here is that we give the steroids starting from the first 3 days from onset for 7 to 10 days. And then afterwards, there's really nothing else that we do. This is the only evidence-based intervention that we have for Bell palsy. And while some people will recover at 1 month. There are people who have flaccid paralysis for 6 months, and the only thing we can do right now is offer this early steroid intervention. And we know there are prognostic factors for Bell palsy to figure out who's going to have a harder recovery. We've talked about complete paralysis, pregnancy, so facial paralysis that develops in the last trimester of pregnancy or in the early puerperium is associated with worse recovery, older age. And although Rumsey-Hunt is not Bell palsy, but a different entity, it's also associated with more sequelae. So let's get back to our question. Could electric stimulation enhance recovery for Bell palsy, particularly for those patients with poor prognosis? Let's talk a little bit about how nerve conduction happens to lead to muscle contraction and how electric stimulation works. So the action potentials happen in nerves and muscles, and they result from a brief depolarization followed by a repolarization that travels down the nerve until it gets to the muscle to produce contraction or in the muscle to produce contraction. And this is an on and off switch. There's not a gradated response for this action potential to happen. In a nerve, the action potential will disseminate and travel, and it'll travel both anterograde and retrograde. This becomes a little bit important as we later in the talk as we talk about intraoperative stimulation. And then it'll reach the muscle and the neuromotor end plate. And we're familiar with the release of acetylcholine, the binding in the membrane, and then the muscle depolarization. In this graph, I'm showing you the thresholds for stimulation to generate an action potential in the different nerve fibers and in the innervated muscle. When we're using electric stimulation, we're just applying exogenous stimulus to create this action potential and depolarization. And it's a little bit different depending on our target. So in this graph, you can see at the very left of the graph that the beta fibers for sensory nerves require the shorter pulse duration in red over here. Then an intact motor nerve is the next curve that you see in purple. And that delta sharp and C dull fibers for sensories require longer pulse duration. And in particular, denervated muscle, which is this blue line over here, which is commonly what we are trying to target in Bell palsy, which is denervated muscle, requires a much longer pulse duration of milliseconds. So does it work? Is electric stimulation effective in any way? Well, now we have good evidence that electric stimulation is effective for recovery after musculoskeletal injury and after CNS injuries. On the left here, I'm showing you a meta-analysis from ACL surgery and recovery. And you can see that after 6 weeks of physical therapy versus physical therapy with electric stimulation, patients do have an improved strength. And this is really where the field started with ACL recovery. And then over here on the right, I'm showing you a meta-analysis for stroke, where patients that had exercise only versus patients that had exercise plus electric stimulation had improved strength and function of their lower limbs. So there are other clinical areas where electric stimulation has been shown to be effective. So as I started exploring electric stimulation for facial paralysis, I did a survey study of physical therapists in Oregon. Physical therapists are the ones that will provide the electric stimulation. And as I said, when we think as physicians of electric stimulation, we might be thinking of a single intervention, but there's actually a lot of different settings. And what I found out was that there was about half of the physical therapists that were pro-electric stimulation and half that were against it. And when I asked why were they pro or against it, I was given the exact same reasons. People that believed in it felt that there was good evidence that showed that it worked and that in their hands they've seen clinical efficacy. And people that didn't felt like there was good scientific evidence that it didn't work and they've tried it and they didn't feel like it was making a difference. So let's look at the evidence and what's been published. So right now there's 8 human trials that look at electric stimulation for Bell palsy. I was a collaborator in the most recent one. and 6 of those 8 have shown benefit, and 2 have shown no benefit. The settings have been very varied, mostly motor, but some even some sensory. And the studies are relatively small. We're talking about studies from 16 to 149 patients. And there's been a lot of limitations in the current research with the low number of patients involved, particularly the short follow-up. Most studies stop following patients at 3 months, and we know that it takes around 6 months plus onset, after the onset, to develop synkinesis. They're largely not accounting for prognostic factors that can predict the recovery. And they mostly use House-Bragman as the outcome measure, which we know is not ideal for facial paralysis. Blinding has also been an issue with the prior studies. So this is a controlled trial that I participated in and collaborated with Argentina. The University of Córdoba had already enrolled patients and conducted the study, and I got involved with the data analysis. And one of the really neat things about this study is that they were able to follow patients beyond 6 months from onset so that we could look at synkinesis, which has been a real concern for people as they consider embracing this therapy. And what we found with this study was that whether they were stimulated or not, they had similar final recovery. There were no increased rates of synkinesis, and the electric stimulation group recovered twice as fast as the one that was not stimulated. So the average length of paralysis was 2.5 weeks instead of 5.2 weeks. Now, there are some limitations to this study. They apparently did not use steroids in Argentina in the emergency room for Bell palsy, which is not the gold standard and not what we would do in the US. And only patients with incomplete paralysis were included in the study. So let me show you what the electric stimulation looks like. In this video, the therapist is using his hand to complete the circuit. And you can see that as he touches the face and the side of the paralysis, he's able to create contraction in the different areas of the denervated muscle. And now we're moving onto the lip where you can see, and so the therapist is able to create specific contraction of the different facial muscles. And this is a slide showing the actual scores and results of all of the participants using an E-face score, which is a clinician-validated scale that looks at a lot of different facial expressions to give us scores about the symmetry at rest, the dynamic function of the face, and synkinesis. And in this graph, the electric stimulation group is shown in blue, and the control group is shown in red. So there is some signal in this study that it's possible that electric stimulation actually does enhance final recovery and even decreases the rates of synkinesis. So as I get back to our original question, is electric stimulation helpful or harmful for patients with Bell palsy? I do think that electric stimulation is safe and it does not appear to increase the risk or severity of synkinesis, and it likely accelerates recovery. But further research is needed with larger trials that control for confounders and predictors of outcome that include patients with poor prognosis, that are well blinded, where patients get steroids, and we use sensitive outcome measures. And I've already submitted a proposal to the DoD, so hoping to hear back on funding on a trial of this nature. And the other area that we need to understand a little bit better is what is the mechanism by which electric stimulation helps patients? Is it because it's keeping the muscle healthy by creating contraction? Is it increasing axonal growth? Is it interfering with feedback in the central nervous system, or is it a combination of the areas above? So now that we know about Bell palsy and electric stimulation, can we use electric stimulation for other causes of peripheral facial paralysis? And one of the challenges with motor nerve and peripheral nerve is how slow recovery is. So we know that after axonometic injury and Wallerian degeneration, a nerve will recover for 1 to 3 millimeters a day. So can we use this stimulation for patients where we're repairing the facial nerve intraoperatively, where there's been stretching or crushing injuries of the nerve, or after we do our surgeries for reanimation, like nerve transfers or free muscle transfer. And one of the challenges in this area is that this group of patients, the ones that are undergoing surgery, are very heterogeneous and relatively rare. And here I wanted to talk a little bit more about the limitations in peripheral nerve regeneration. When a nerve is regenerated, it sprouts, as we're seeing here on the left, in all directions. So it really sends axons to go everywhere. And it's really until they reach their contact and their target organ, as you can see here on the right, that then they start getting cell signaling to increase the growth into that area. But with this, what we see is that the growth of the axons is very slow. Axonal misdirection to incorrect organs is a reality, is likely the major mechanism behind synkinesis. And there are limitations in how much a chronically denervated muscle can achieve functional recovery once their axons finally make it to that end organ. This is what I consider to be one of the best studies that looks at electric stimulation after facial nerve surgery for reanimation. And this study is by Fabian Volk in Germany. I collaborated with him in some other projects. And he took 39 patients that had had facial nerve surgery and he stimulated him. And while there were no clinical differences in their facial movement and function, he did find in electrophysiology that the stimulated group, which is this graph here in red, had more rapid recovery than the groups that were not stimulated, the patients that were not stimulated in blue. So now let's switch topic to our second question and talk about electric stimulation intraoperatively. Can we use it to enhance facial nerve recovery or other motor nerves in the head and neck area? Well, there are already 4 human clinical trials that have shown efficacy of perioperative electric stimulation. And I say perioperatively because sometimes the stimulation is given during surgery, and sometimes an electrode is attached and the stimulation is being delivered in the recovery room, and then the electrode is removed after the stimulation is completed. And you can see here a diagram here where you're seeing digital nerve repair and the electrode being attached, and then the stimulation happening in PACU. In this, trials have looked at medial nerve decompression, ulnar nerve decompression, spinal accessory traction during neck dissection, and the digital nerve injury, all of them happening at University of Alberta in Canada. And I figured I would start with the one that's most relevant to us as head and neck surgeons. So for the shoulder strength and spinal accessory, they used intraoperative stimulation. You can see here the electrode around the spinal accessory nerve. And it's impressive to see what they found. In this graph over here, you can see in the left, the group that was not stimulated, and on the right, the group that was stimulated. And at baseline is blue, so at baseline, shoulder strength and function is the same in both groups. But postoperatively, it's really the electrically stimulated group that has improved function. And this outcome is measured at 1 year after surgery. And here's the data on ulnar nerve decompression. And what you can see here is improved grip and key pinch in the electrically stimulated group up to 3 years after the surgery. So these are outcomes that really matter to our patients. So how does this work, this perioperative, intraoperative electric stimulation? It's really incompletely understood. What we think is that stimulating proximal to the coaptation, proximal to the injury, mimics the intracellular calcium wave at the axotomy, and then that there's a retrograde action potential dissemination towards the cell body that then promotes genes that are associated with renervation, in particular brain-derived neurotrophic factor. And here's a diagram showing all the intracellular upregulated signaling that leads to nerve regeneration. Now, there are challenges in the intraoperative nerve electric stimulation. The most effective setting is still not known. In animal data has shown that shorter duration may be as effective as the 1 hour intervention, which we've been talking about. So it appears that 10 minutes are just as effective as 1 hour, and that 2 hours is not more effective than 1 hour. The type of nerve fiber may affect the optimal settings, and the type of injury to the nerve might also affect the optimal settings. And for facial nerve in particular, we have the challenge that some animal models in rats have shown lack of efficacy for this intervention, and some have shown to really help and be effective. So why is that? We don't really know, but we think that the high axonal density and the several fine muscles in the face that we use for expression play a role. We have a very short distance between the facial nucleus to the motor end plate in the face in comparison to the hands. And the sensory input in the face remains intact, which is different from other peripheral nerve injuries. The cross-facial nerve graft is a very unique model to study intraoperative stimulation. When we're doing a cross-facial nerve graft, what we're doing is we're taking an intact, normal, healthy facial nerve, we're sacrificing a branch, and we're connecting it to the affected contralateral paralyzed side. And we do this using a long cable graft, typically a sural nerve. And in the traditional way, we're doing this in 2 stages. In the first stage, we connect the donor nerve to the sural nerve, and then we allow it to grow for 6 to 12 months. And in the second stage, we then connect it to the recipient. And there's a lot of advantages to using the cross-facial nerve graft. It's the only nerve that can give us spontaneity of smile and facial movement, and it really has negligible donor morbidity when we're selecting 1 to 2 branches. But the disadvantages really limit its use. It takes a long time for it to grow, and in adults, it's hard to predict if the growth is going to produce significant movement by itself. So I'm getting back to that first slide where I told you I would talk to you about what Cleveland Clinic is doing for intraoperative stimulation. And this is a project that's really been led by Dr. Byrne, Dr. Ganter, and Dr. Hadford. And I know I've been collaborating closely with Hannah Rosen, which is used now and enrolling and participating site for this study. And what they're doing is what you all are doing is you're randomizing patients to receive intraoperative stimulation or not, and then comparing axonal counts and clinical outcomes for those patients. And when you're looking at the axonal counts, it's going to be accounting for the number of axons that are introduced by the donor facial nerve branch and by the number of axons available in the sural nerve. And we're using a device that is readily available, so I have no financial relationships to Checkpoint, but we already use it intraoperatively, and it's already in our shelves to do diagnostic and intraoperative stimulation to see facial muscle contraction during surgery. And this same device is able to give us the intraoperative stimulation. So I can see a lot of clinical scenarios where intraoperative stimulation can be helpful in cross-facial nerve graft, including improving our outcomes for free muscle innervation, or using it after a babysitter procedure with a masseter or hypoglossal nerve. There are several options for gracilis free muscle transfer innervation, the masseter by itself, the cross-facial by itself, particularly in children, and more commonly dual innervation, where we're trying to combine the power and reliability of the masseteric nerve with the spontaneity of the cross-facial nerve graft. And I put here a cross-masseteric nerve because this is a relatively newer procedure to innervate the gracilis. And so I'm showing you here how a single sural nerve is used, and it's connected to both a masseter nerve and a facial nerve branch. And because of the size match, you can do that to a single sural nerve. I recently conducted a survey of international Third Childbirth Society members to look at the preferred innervation for gracilis-free muscle transfer, and not surprisingly, dual innervation, as you can see here in blue, is really the most popular approach right now. And I know that the babysitter with the cross-facial nerve graft is not something that is commonly done at Cleveland Clinic. So here's just a patient of mine after vestibular schwannoma. You can see her before reanimation here with complete flaccid paralysis. And then here, after her cross-facial nerve graft, so she is no longer using the bite to stimulate her smile, but rather just smiling and using that cross-facial nerve graft. So can electric stimulation be used intraoperatively to enhance facial nerve recovery? Potentially, in brief, intraoperative electric stimulation can be used to increase recovery after crush or transection or even interfacial reanimation. And in my opinion, the two-stage cross-facial nerve graft offers a unique human model to really study this information and look at the axons and how they're regrowing. So as I look at the two questions that I started my talk with, is electric stimulation helpful or harmful for patients with Bell palsy? And can electric stimulation be used intraoperatively? I think the answer to both questions in my mind is that these interventions are safe and probably helpful, but more research is needed. Now, I am a surgeon, so I couldn't not talk about some of the surgeries we're doing over here at OHSU that I think are pretty cool. So we are using free strap muscles, so taking sternohyoid and omohyoid and using it as a free muscle to reinnervate smiles with two vectors. We've published this, including a video of how to harvest it. And here's the before and after for the first patient that we treated. So you can see him here before. Oh, maybe. There we go. So he had a traumatic brain injury and he'd had a temporalis tendon transfer before. And then we were able to revise that with a free strap muscle. And you can see that the two vectors do afford us that upper lip elevation. The flap has been really impressive because once you're done with the harvest, it really tends to weigh around 15 grams. So a really small muscle where we don't have to dissect within the muscle fibers to be able to create the two vectors. I want to thank the Facial Nerve Center here at OHSU. I wouldn't be able to do the type of surgeries and work that I do and to do the research that I'm doing without them. And to invite you all to come to the Portland rhinoplasty course that's happening in the last weekend of July here in Portland. We have an incredible group of speakers lined up. And as Jamie was saying, you can ride the tram when you come here. I have a picture here of the tram, which allows us to commute from the top of the hill where the general operating room is to the waterfront where the outpatient clinics are. And in the background, you're seeing Mount Hood, which is our local volcano. I think I went through those slides pretty quickly as I'm looking at the time, but I wanted to thank you for your collaboration in this area, to thank our patients for allowing us to do this type of more innovative, newer interventions, and to take any questions that you might have.
Thank you, Dr. Loyo, for that very exciting topic that I didn't know that much about personally. But my brain is already thinking about how we can apply this in head and neck world. But I'm going to open up to questions. Dr. Byrne, Patrick?
Yeah, first a comment, Myriam, phenomenal talk. There's so much I could ask you questions about, but we don't have 3 or 4 hours here because that's probably what I would like. I'm going to focus on this functional electrical stimulation after Bell's and your findings that, the long-held concerns that it may enhance synkinesis are perhaps not something we need to worry about. One of my questions, what are your thoughts about uniformity of the stimulation protocols? In the study you did, for example, and in the reviews as well, is it your intuition that if it's helpful, then how the stimulation is performed, how frequently, the settings where the probes are placed, the duration, how many months, that may have an influence on both recovery and aberrant regeneration, and how might we solve for that?
Yeah, great question. Yeah, so I mean, part of what I wanted, I think the first question that I always tackle is why did we think that it created synkinesis? Where was that where was that coming from? And I think there's really a very different patient that has Bell palsy and is recovering in 1 month and is starting to move, and a patient that really has gone 3 months with no movement, that was told this was going to improve on its own, and it's really not, or 6 months with no movement. And I think those patients that really have gone months without being able to move their face are more willing to try different interventions. So electric acupuncture, electric stimulation. But those patients that have had paralysis for that many months are the ones that are going to develop severe synkinesis anyhow. So I think there's a selection bias for clinicians that are treating patients where they're seeing the worst performers come that have tried everything. So I think a lot of it is coming from that. And then thank you for asking about the settings, like, so if we're going to do it, how do we do it? In part of my talk, I wanted to talk about how not all electric stimulation is created equal. We can have settings that just stimulate sensory nerve fibers or motor fibers or denervated muscle. And I didn't even go into high vault. That is a type of setting that it's meant to increase tissue regrowth and tissue healing that's used, for example, in diabetic ulcers. So I think the most robust evidence is for denervated muscle, millisecond pulse duration. And that while we don't know what the optimal length is, that these are therapies that patients can do at home with their own stimulator device that takes around 40 minutes to do. In most of the trials that had efficacy was considered, compliance with treatment was considered 5 days out of 7, 45 minutes intervention at home. And the nice thing about how to check that you're doing the stimulation correctly is that you get contracture of the muscle. And so if you're seeing contracture of the frontalis, if you're seeing closure of the eye, if you're seeing closure, elevation of the midface, then that in itself builds in the protocol a way to check that the stimulation is being done correctly. So yes, I want you to know that there's a lot of nuance to the therapy, but also it's not that complicated to implement it right now.
Yeah. Well, your point about the segmentation amongst Bell's patients is a really great one, and I'm sure you're aware, but for the others on the call, it's worth looking up. There's a study by Peterson in the Netherlands from about 20 years ago. They followed 2,500 patients for 25 years. And it looked at in that study like there's a clear demarcation where there's a bimodal distribution of patients who either recover within 3 weeks or they don't recover for over 3 months. And Bell's studies, I've long thought, probably should distinguish between those two groups and looking at the results for the interventions as well. So it's a great point. Thanks, Myriam. Great talk.
I have a question. So,
Yeah, sure.
I think, like the first part about muscle, denervated muscle, doing regular exercise to stimulate and how that could impact the outcome. To me, logically, that makes sense. But how does like a intraoperative one-time stimulation lead to improved long-term outcome? That's number one. And number two, um, like when we are like, doing facial nerve and thyroid surgery, we're always taught like, don't overstimulate the nerve. It can cause nerve fatigue and weakness over time, right? So how does that kind of play together to actually help the patient?
Yeah, great question. So yes, like electrically stimulating a muscle does create contractions of the muscle and does prevent atrophy. A muscle that is denervated will start atrophying even within hours of losing motor input. And I think that electric stimulation sometimes gets a bad reputation because of it being used in addition to exercise in healthy muscle. So I think we've all seen those infomercials where you're like wearing this strap in your belly and it's like contracting and working out while you're just watching TV. And that is in a healthy, innervated muscle. And there are some top athletes that use, strength training and then electric stimulation to create further hypertrophy, but you really have to take it to a very high level of intensity. So for denervated muscle, that's different. Like the denervated muscle really is not contracting at all, has lost all neural input. And we know that electrically stimulating it will keep it healthier and will prevent atrophy, even in the face. Like there are studies looking at how the average width by ultrasound of the facial muscles really decreases from denervation, and how electric stimulation is able to preserve the volume of that muscle. So denervated muscle having contractions, when we think it's going to eventually be reinnervated, in the case of Bell palsy, in the case of traction of the recurrent laryngeal nerve, that appears to be a good thing. Now, electrically stimulating a muscle that will never be reinnervating again is more like Superman, and like how Reeves was getting electric stimulation after a very high transection of the spinal cord. That has more limited value because in the end, physiology catches up and we're not really able to get the muscle to be a healthy muscle that's contracting. Now, it really seems like intraoperative stimulation is taking advantage of retrograde transmission. And so it's not stimulating distally, it's not going to the motor area, it's not being the electric stimulus does not pass a coaptation that you've done in surgery. It really goes retrograde. And so it's telling this neuronal cell body to start sprouting and to regenerate. And there's evidence there that very high frequency can damage the neuronal cell body. So you really leave it at low frequency voltage. I think there's a difference between thinking that the electricity we're applying is damaging the nerve, the cells, or the muscle, or fatigue in the intraoperative diagnostics. And so I'm not sure exactly why like excessive stimulation would lead to fatigue. I wonder if it's more related to traction of the nerve while we're stimulating it. And I really have been very impressed with the newer stimulators that are able to give us bipolar, fascicle specific stimulation, and that allow us to control the settings that we're using. I often start at like half a milliamp, and with pulse durations that are like 80 microseconds. And then if I lose intraoperative stimulation, I have a lot of room to go up to 1 milliamp, 2 milliamps, 150 microseconds. So I no longer use the facial nerve monitor where you put the electrodes in to close the circuit. I really just do direct nerve stimulation and then look at the muscle contraction. I hope that's helpful to think about how we use it intraoperatively.
Thank you. All right, well, anybody else with questions? If not, we can end early. Thank you, Myriam, for giving us extra 15 minutes to grab coffee and enjoy the morning.